Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, we sat down with Dr. Joseph Sullivan, director of the Pediatric Epilepsy Center at UCSF, to discuss some of the clinical distinctions between Lennox-Gastaut syndrome and Dravet syndrome, two rare epileptic encephalopathies. Throughout the interview, Sullivan provided clinical commentary on the unique diagnostic profiles of each disorder, the evolving role of genetic testing, and the future of targeted therapies, specifically disease-modifying treatments. In addition, he touched on how the clinical trial landscape for these disorders continues to evolve, emphasizing the need for biomarkers and innovative designs. Let's dive into it.
As a pediatric epilepsy specialist, I think that LGS and Dravet couldn't be any more different. I know they often get lumped together because there's a lot of clinical trials that are being done in parallel with each of the diagnoses, but they really have completely different phenotypes. So, for example, Dravet syndrome typically presents in the first year of life with either hemiclonic seizures or other generalized convulsive seizures that can be prolonged but don't have to be, are often associated with fever, but again, don't have to be, and then unfortunately still have an overall trajectory of being treatment resistant. And now we know greater than 90% of those patients that the underlying etiology is linked to pathogenic variants in the SCN1A gene. Compared to Lennox-Gastaut syndrome presents later in childhood. Typically, it's around 3, 4, 5 years of age, but can even present upwards of 12 years of age. And even the new ILAE classification say that it can actually present up to 18 years of age. And typically those the presenting seizure types for Lennox-Gastaut are very different, right? These are the tonic or atonic seizures. They may have a pre-existing epilepsy diagnosis of a different epilepsy syndrome, most commonly infantile epileptic spasms syndrome, and then they evolve into Lennox-Gastaut. And so there's a whole host of background etiologies that contribute to the ultimate Lennox-Gastaut phenotype in comparison to Dravet, which is really, like I said, 90+% from pathogenic variants in the SCN1A gene. So I do think that maybe as adults, as Dravet patients become adults, if you didn't know any of the childhood history, some of those patients may have tonic seizures and may have tonic seizures primarily during sleep. So that could maybe be misdiagnosed as Lennox-Gastaut. Or maybe they would say it's a Dravet syndrome patient with Lennox-Gastaut features. I don't necessarily love that sort of classification, but I can see that in adulthood, maybe there may be some similarities if you're looking at those patients at that single point in time.
Well, it's interesting to hear some of the differences. Obviously, like you laid out, that there are some pretty noticeable differences between these two cohorts. Obviously, with patients with Dravet syndrome, there's more of the genetic testing aspect that comes into play here. So, can you talk a little bit about how the diagnosis around these disorders, and specifically Dravet, has kind of changed or evolved over the years? And how have we learned more about how to better diagnose, and then also the subsequent steps right after the diagnosis as well?
Yeah, so I think this has really been a huge success story because the availability of genetic testing has allowed clinicians who may not even be that knowledgeable about the early presenting phenotype of Dravet syndrome to basically stumble into the diagnosis. But then this improved diagnosis at an earlier age, I think, has raised awareness. So now people, when I go and speak at teaching and educational conferences with neurology residents, they all know what Dravet syndrome is, which is really, really a breath of fresh air, because just 10 years ago, we had, well-trained practicing child neurologists that missed, myself included, that missed Dravet patients. So I think that the availability of genetic testing and now understanding that patients with Dravet syndrome are usually developmentally normal at their initial presentation. I think that was a historic barrier where people thought, how could someone have a severe genetic epilepsy if they're presenting with their first few seizures at 6 months of age and they look developmentally normal. Well, in fact, that's more the norm than it is the exception to the norm. So I think it really has been education, availability of genetic testing that's really allowing us to make this diagnosis sooner. And I think that's actually contributing to improved outcomes because we can, one, avoid contraindicated medications, which have been very well studied. And we know that contraindicated medication use can impact long term outcome. And more importantly, we can treat them with medications that we know to be safe and effective. All right. So we have the luxury now having a few large scale phase 3 clinical trials with demonstrated efficacy of stiripentol, Epidiolex, and fenfluramine. So I think that has really changed the treatment landscape as well.
Yeah, the evidence has definitely mounted over the years for sure. And also, it kind of brings me to my next question. We're not really in the early stages of genetic testing anymore. Now it's kind of a lot more commonplace, especially across a lot more different states in the United States. So I'm curious from your perspective, is there anything that we can do as a clinical community to even enhance genetic testing to kind of take it to the next level? Is there things from an educational perspective or even just the process of genetic testing that you, as a clinician and someone who kind of oversees a center, kind of look at it, maybe kind of stump you or is a little bit confusing at times?
Yeah, I mean, this is evolving very, very quickly, and I have to say, I may be a little bit of a holdout. I mean, there's big pushes now to do whole exome and even whole genome sequencing, and I certainly see the value in that to be able to look for, yet to be sort of more clearly defined epilepsy genes. I guess so I think there's a big movement. I have some of my colleagues that are just doing whole genome sequencing and skipping epilepsy panel testing. And I don't necessarily have any problem with that. I guess my own personal practice so far is, when I think about the core epilepsy genes, where the epilepsy is the core part of the phenotype, those really are covered by many of the epilepsy gene panels. So if I can do a panel, not have to necessarily send the testing of the parents up front, I get the result back more quickly. And then if I get a result, then I have my answer and I can proceed with the knowledge that's gained from that. And then if there are other unanswered patients, right, then we can maybe reflex to exome and genome as those genes and the interpretation of those large scale genetic profiles actually becomes more fine tuned. So I think a lot of this is being driven by costs and resources. So as the cost of the testing comes down, that's great. But there's still the expensive and limited resource of genetic counselors, right? And those that can help us clinicians interpret some of these genes that are still in the sort of, ultra rare sort of categories.
We're going to take a quick break from our conversation with Dr. Sullivan to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, on June 20th, the European Commission approved efgartigimod as a monotherapy to treat patients with progressive or relapsing active chronic inflammatory demyelinating polyneuropathy. The decision followed a positive recommendation from the Committee for Medicinal Products for Human Use, which reviewed data from the Phase 3 ADHERE trial. Days later, on June 24th, the FDA approved an expanded indication on GE Healthcare's PET imaging Vizamyl to include both quantification of amyloid burden for patients with suspected Alzheimer's disease and use in therapy monitoring. Originally approved in 2013, this new indication should help neurologists better assess treatment response to anti-amyloid therapies. And lastly, on June 25th, Grace Therapeutics formally submitted its new drug application for GTX-104, an injectable formulation of nimodipine, as a treatment for patients with aneurysm subarachnoid hemorrhage. The therapy is delivered via intravenous administration, potentially eliminating the need for nasogastric tube administration in unconscious or dysphagic patients. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Sullivan.
Dr. Sullivan, from your perspective, obviously you have a hand in a lot of clinical trials yourself, and you're somebody who's in the research realm as well. So, what types of emerging research do you feel is kind of leading the field in terms of advancing the care for patients with LGS and Dravet? Just talk a little bit about some of the things that are maybe coming up the pipe, not necessarily agents, but things that are coming up the pipeline that the clinical community should kind of take notice to.
Well, this is where I think arriving, I may actually put my foot in my mouth a little bit, right? This is where I think arriving at a precise genetic diagnosis can and really guide treatment specifically for Dravet syndrome, because now there are some different potentially disease modifying therapies that are getting at the root cause, right? So to get at the underlying SCN1A haploinsufficiency, and there are a couple of different clinical trials that are in various stages right now that are really aiming to upregulate that NaV 1.1 sodium channel to get beyond just the anti-seizure medication or seizure management and try to address the whole host of other comorbidities that are so pervasive, in the disorder. So without a genetic diagnosis in a patient with a clinical diagnosis of Dravet syndrome, they may not be eligible, for those clinical trials. And the LGS story, I think, is a little bit more complicated because there are literally, probably upwards of 100 genes that could be the ultimate cause of Lennox-Gastaut syndrome. Yet there are not necessarily pipeline therapies that are far along for even a handful of those genetic background etiologies. And so we are still left with sort of the symptomatic treatment of seizures with anti-seizure medications for patients with Lennox-Gastaut. And I think, there's been a pretty nice sort of roadmap in terms of how these clinical trials can best be designed to make sure that we're including patients that truly have, Lennox-Gastaut, and so that their seizures can be countable and we can measure them over time with whatever so treatment intervention is actually done. I do think that there's an increasing sort of use of these N of one trials. So there are different companies out there that are making ASOs and things for specific rare genetic epilepsies that may actually result in a Lennox-Gastaut phenotype. And so I think we're going to be hopefully seeing, more of the results of those N of one trials, in the coming years.
Yeah, we've definitely seen the rare disease community, especially some of the smaller groups of epilepsy, kind of rise up a little bit over these last couple of years. There are a few kind of trials making their way through right now that we're paying close attention to. Dr. Sullivan, we always appreciate you taking some time. I have one last question for you. I sort of similar question to the last one, but a little bit different. As someone who's obviously conducted a lot of phase 3 studies, and the field of neurology is constantly evolving over the last couple of years, how do you foresee us getting even more creative with some of the clinical trials that we have for Dravet and Lennox-Gastaut? Just talk a little bit about, from an innovative standpoint, how can we continue to kind of change and strive for better for the trial perspective?
Well, I think one hot area is sort of the discovery of biomarkers that could potentially give us some signal as to whether or not the treatment is having its desired effect. And maybe we could use that along with the conventional sort of seizure diaries and counting, right? Because we're still kind of in that stage where we're expecting parents and caregivers to count seizures and put them on a diary. And that's what gives us our primary efficacy outcome measure, right? Do seizures improve or not? And we know that there might be some variability and inaccuracy overall with seizure counting, but I think we've gotten a lot better with that as study sites, clinicians, PIs, and parents have kind of gotten into the weeds and get into the details and trying to call an apple and an orange and orange. So we say this is a seizure. Not only is it a seizure, but it's this type of seizure. And if it doesn't fit, then give me the description so we can actually reclassify or come up with the appropriate classification so that everything is counted accurately. So I think that's one thing. And I think related to that are some advances being made in seizure monitoring devices. I still don't think that there's one that's ready for prime time that we know is, 90% plus, accurate in terms of false positives and false negatives. But I think if we could take the sort of somewhat observational component out of seizure counting, that would be great. And then I think specifically to the, sort of DEE population of Dravet, Lennox-Gastaut, the comorbidities are so important, right? So we know that the seizures are a major determinant of quality of life, but so are the comorbidities. And right now, we only have sort of neuropsychometric and testing, as well as patient questionnaires to understand how these comorbidities are changing in a clinical trial over time. So it'd also be nice to try and innovate and see if there are other, again, biomarkers, I think is the buzzword here, that could maybe predict whether or not the intervention is having, the desired impact.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.